Hello, everybody. This is Rick Reingans from the Department of Sustainable Development. This is a short lecture on sustainable development and health. I usually use this as an introduction to SD 3850, which is Sustainable Development and Health. But it's also, I think, really a useful introduction to our class on coronavirus, health, development, and resilience. And so I'm just doing a short version of this so we don't use class time to do it, but I'm hoping everybody will take some time and review this lecture to help us think through these ideas. If I can make this work. Here we go. Okay, so we've got three objectives for this short lecture. The first one is to introduce the relationship between sustainable development and health, just to have us start thinking about it. And the goal here is to really start to see these two as related, see how the connections work between them. Our second objective is to look at how do we think about the burden of disease. So how big is a health problem? And how do we describe it? Can we think quantitatively about this? Can we think about how much of a problem it is and for whom? The third one is to talk about risk factors and social determinants of health. And these are big concepts that we'll talk about in a number of different ways, but it's just at least to get us thinking about these issues. Okay, so if we think, kind of key questions we want to look at is, what are major causes of poor health? How do we systematically measure and assess health problems? And how do social and ecological factors affect health? And those are kind of our three, those questions correspond to the three objectives. Okay, so I want us to just kind of think about different settings that we might find, and again, seeing health around us. And so this is a cholera ward in Matlab, Bangladesh. And so this is a part of Bangladesh that's often characterized by flooding, and so people kind of have a lot of access to water, and that water can often be contaminated. So this is a ward where actually the children in this ward are receiving treatment for dehydration due to cholera. And we can think about this ward as being the kind of what health is about. This is where people get their health, but it's hard to understand this picture if we don't step outside of the cholera ward, step outside of the clinic, and think about the context around it. And so this is just right kind of down the waterway from that clinic. And so it's important to think about people who are living, so here's this place where people are living close to the water, where they don't have a lot of resources, where they don't have a choice of how they interact with that water in many ways. So they have limited choices, right? So the people who are likely to end up in that cholera ward are people who might be able to, whose children are more likely to be undernourished, who might not have had access to things like zinc or vitamin A, which are preventative against diarrheal disease. They may also be there because they have lower immune systems. In some sense, the parents and the children who end up in that cholera ward are fortunate because they actually have a clinic that's nearby and they can access it. So there's others yet that can't do it. So just when we think about a health problem, we need to step out and think about what's its context. How does the ecology and the social dimensions around it influence the patterns of health that we see? This is another image from a different part of Bangladesh. This is from an informal community in Dhaka. And Dhaka is the capital. It's one of the most densely populated cities or places on the earth. And it's densely populated because people are being pushed from rural areas through a combination of environmental loss, in part due to climate change, and also kind of population demographics. You can just see it a little bit. So this is an informal settlement. It's an area that's in a lake in the middle of town. You can almost see it off to the left. There's actually a number of high rises with luxury apartments, really beautiful apartments from people who can afford it. Maybe they work for the government or the university. The people who live here at this point in time are about 125,000 people who lived here. And it's an informal settlement because the government doesn't recognize that it exists. And the reason they don't recognize that it exists is because if they did, then they would have to provide basic services. They would provide a health clinic, they would provide schools, they would provide electricity, water, and basic sanitation. But if they don't recognize that it's there, then they don't have to do this. Shortly after I took this photo, that the government actually removed all of these houses. The next time I was back in Dhaka, similar houses were back again. And so this is, again, if we think about the health conditions for people who are living in this community, so they don't have access to clean water, they don't have sanitation, they don't have clinics, but it's their social context is directly influencing the health threats that they face. So the lack of sustainable development in this context, both in the rural communities that they likely came from and in this urban setting, both of those influence their health. If we looked a little closer at this setting, we'd see some more things. So we would see things like right here, if you look at this. This is what's called a hanging toilet. So when people in this community have to defecate, there's no sewerage, there's no kind of formal sanitation. So this are all hanging toilets, and hanging toilets are basically a private place to defecate and urinate if you're lucky enough to have a place like that. So when people use them to go to the bathroom, the waste goes down into this waterway and basically gets diluted. You can kind of see, if you think about it a little bit, you can see that the color of the water is because of it's kind of green because it's nutrient rich, high in algae, in part because of the waste. Also, if you look closely, you can see this line right here. And this line is actually a water line because the government doesn't want people to live in this community. They don't have kind of proper piped water. And instead, people tap into water mains on the kind of the formal settlements around in the city, kind of around the lake. And watermen bring kind of pipe water over and basically allow people to use or sell that water kind of illicitly in this community. The thing to think about is that this water, if there's any crack in the pipe, and if there's any moment where there's negative pressure when the water's not going through it, and actually there's incredible opportunities for cross-contamination for this waste to come into this pipe and then to get pushed back into people's water use, right? So we can just think about the social context, the broader social context, which puts people here, which then creates an ecological setting that's really conducive to disease spread, and it affects their health. And so if I think about the ecology of inequality as it relates to health, I think about this kind of a context. This is from India. We can think about people, kind of how urban settings create opportunities for foodborne disease and other illnesses as well. Again, what we want to think about is how social conditions might create the conditions for disease transmission. I won't dwell on that one. Okay, so we can think about that relationship around us in many ways. In many ways, health is defined as a part of sustainable development, but also sustainable development contributes to health. We'll talk more and more also about how health and good health can actually contribute to sustainable development through things like improvements in education. Okay, the second question I want to look at is how do we think about and how do we talk about burden of disease? And so this is the question of how important is a particular disease. And if we think about right now, coronavirus as an example, we can think about it in different ways. We could talk about how many people have died from it. We can talk about how many people are sick with it. We can talk about how many cases have been identified. But how we talk about it and how we count the disease often affects how we account for it, how we consider it and the weight that we give it. All right, so we're going to think about that. And this also, we'll see that this notion of burden of disease is really helpful in thinking about who bears that burden, which is a central question for us when we talk about the social determinants of health. Okay, so let's think about burden of disease. So let's talk about some basic definitions that are used in epidemiology and public health to think about burden. And the first one is incidence. So incidence is the number of new cases in a given time frame per unit of population. And so I can define this in a couple different ways. And so I could think about it in the case of coronavirus. I might think of there are 10 new cases per 10,000 people per week. Or I could think about it per year, but in the case of something that's moving really quickly like coronavirus, I might want to know much more about how many cases are being identified now. I could think about it per day, but that's maybe a little bit, the way we measure it might not be accurate enough to know if it's different one day versus another. This notion of cases is also really important. We don't often or don't always know who really has something or not, right? And we could define, is a case, for instance, in the example of coronavirus or of COVID-19, is a case an infection where that kind of novel SARS-CoV-2 virus has started to replicate and you now have an infection? Is it when you actually have developed signs of disease? So you have COVID-19, you have symptoms that are related to it. Or is it when you have an infection that has been laboratory confirmed, right? So this notion of cases, when we look at data, we want to think carefully about what do we mean by cases. And again, it's really important for instance to know kind of not just the numbers, but we want to know it with respect to some unit of population per 10,000 people, per 100,000 people. And so that's really important for us, right? And again, we could be more specific. We could talk about rates, these incidence rates based on age, by gender, by race. We could think about it based on by economic status, but that's a little bit less likely to happen, at least in typical epidemiology. But we think about at least age, gender, race as examples. Okay, that's incidence. So this is kind of the kind of what's happening right now. Also, people talk about prevalence, and prevalence is the number of people living with a condition at a point in time. Right? So this is important to distinguish, so we can think about it. It's not how many new cases, it's how many people have it. And this is really relevant for things like chronic diseases, where the number of new cases or incidents of something like diabetes might be relatively small, but the number of people who are living with the condition might be great, right? If we think about this in the case of COVID, we want to know not just how many people have had it this year, but how many people have it now? How many people are currently suffering from it? And so how many think of this as active cases, but it's particularly important for chronic diseases, which last much longer, and where incidence or new cases is just a small fraction of what the total burden is, right? And so some of these are better for understanding certain conditions, and some are more important for other conditions, right? So if we think about that a little bit, let's think about prevalence or incidence. Which one is going to be more important, and which one is kind of tells us more? So we can ask ourselves, is cervical cancer becoming a greater problem in middle-income countries? And countries like India or Brazil, is this becoming a greater problem, right? So we can think about what makes more sense. In this case, prevalence would tell us something about the burden, but it wouldn't necessarily tell us whether incidence or the number of new cases is changing. Like many things, cervical cancer can go underdiagnosed. So if we think about incidence, we do want to think about how do we define a case? Is it an actual case that's developed, or is it a case that's detected? So you think about it in that case. So maybe incidence would be more important. If we think about what's the primary cause of child mortality, we usually think of this as an incidence because it's an incidence of mortality from a particular condition. If we think about another kind of question, if we thought about what is the greatest problem, health problem in India, this is a tricky one, right? Because if we think about it from the point of view of a health system, we might be interested in what's the burden of people we need to treat. So people with chronic disease, with diabetes, with heart disease. In India, this is it's a huge problem. There's an increasing problem of chronic diseases, and it's not just a problem of the incidence, but it's the problem of what's the prevalence of people who have developed these conditions and then have them for the remainder of their lives. And so sometimes the health problem, in some cases, prevalence will be more important, and in some cases, incidence will be. But typically, we think of prevalence as being a better measure of what's the problem, what's the magnitude of the problem. Again, if we think about this for COVID, we might become increasingly less interested in how many people who have had it this year than how many people have it now, how many people are hospitalized now for the condition. Okay, so I think these are just two different definitions, both of which are useful, but maybe different usefulness in different contexts. Okay, when I think about the idea of disability, and this is important because if we want to consider, typically we focus on health as mortality. It's easy to focus on that, but often we overlook the effects of disability. Again, we can think about this for COVID. We could think about how many people have died, but we also will increasingly think about the people who live with long-term disability as a result of it, right? It's easier to notice death, but sometimes it's hard to understand disability. So let's think about what do we mean by disability in terms of health. And we can think about this as an impairment in health and functioning short of mortality, right? So both kind of poor health, but also kind of inability to carry out certain roles or difficulty in carrying out certain roles or activities. Sometimes people refer to this as morbidity, but that word morbidity is used in different ways. Some people think of it as the number of non-fatal cases, but some people also think of this or talk about it as morbidity as the magnitude of disability. So those are kind of different. So, but sometimes people contrast morbidity and mortality. So things that make people sick and things that kill people. We could think about numbers of people with a particular case definition, but that's a problem if we wanted to compare across different outcomes, right? So if we wanted to think of what's more important, diabetes or COVID, or would we count a case of COVID as the same as a case of diabetes? Well, this is really hard because the two conditions have differences in severity and they have differences over time. And so there's a number of efforts to try to capture these different levels of severity and duration of disability. And in part, it's about trying to capture these so we don't overlook them and only focus on mortality. We kind of want to avoid just focusing on mortality. So one of the first efforts to do this was called the Global Burden of Disease. And this was started before then, but it was first published in 1996. It was a collaborative effort by the World Health Organization and Harvard University. And it was really asking a simple question of what illness is most important and where. And this is important because otherwise you often have people who worked on diarrheal disease who were saying diarrheal disease is the most important thing. And then you had people who worked on malaria who said malaria is the most important thing. Or you had people who worked on mental health who said mental health is the most important thing. And it's hard to make objective comparisons between what is the most important problem and where should we put resources and kind of how to get those in sync. And oftentimes who could make the best case for their health outcome was who got the resources. And so this effort, the Global Burden of Disease, attempted to develop standard methods for estimating morbidity and mortality and comparing these across populations. This effort's continued since then. It moved to the World Health Organization exclusively for a while, and then maybe 10 years ago moved to the University of Washington's Institute for Health Metrics and Evaluation. And they regularly publish these results. And the other thing you'll actually see things from this same institute. This institute is incredibly well funded right now, primarily by the Bill and Melinda Gates Foundation. And they're one of the sources of estimates or projections of COVID-19 mortality and kind of what's the future of the epidemic, of the pandemic. Again, if we ask this question about what illness is most important, it turns out it depends. It depends on where you are and for whom. And so it really is a thing of not just one disease, but it's understanding what are patterns over time, place, and people. Okay, we think of a few more questions. We could look for patterns. What patterns do we see over country, by region, by age, by gender? And as we do these, just as we're trying to understand why do we see differences by race in hospitalizations for COVID-19, we want to ask why. Why might these patterns exist? And so that's an important kind of part that we want to get to. What's the underlying ecology? What are the underlying mechanisms between disparities in health outcomes? Okay, so we can think about this a little bit and just ask ourselves, why might we account, or what might account for differences across space and time for different conditions? And so we think about heart disease. So where would heart disease be more important? Is it more likely to be common in Malawi and sub-Saharan Africa or in the US? Well, it turns out it's more common in the US. Well, why? Part of it is the age structure of our population. We have more older people. People survive long enough to get heart disease. What are other reasons? Well, we may be less physically active. Our diet, we're more likely to be obese, and we have the luxury of over-consuming, right? So we can think of that. What about respiratory infections? Where might they be greatest and for whom? Right? Well, we could think about cities, or because of air quality, outdoor air quality, or places where indoor air quality might be low because people don't have access to kind of more modern sources of energy. So they rely on cook stoves and biomass fuel for this, right? And we can think about for whom. Well, typically it's younger populations and older populations are most susceptible to it, right? So when we think about patterns, right? So we already have an ability to think through these patterns of disease. We can think about what are the proximal causes. So what are the things that are really driving that difference? And usually it's about risk factors. It's about what we eat, what we do, who we're exposed to, what are the environments we have. In some cases, it's about individual characteristics. It might be about age or gender. There's something about kind of genetic differences even between populations. And the other one is context. Our context, our social and environmental context, which are obviously related to each other, often influence our proximal causes, right? Our context changes kind of whether we can, who's infected around us. It changes whether we have access to personal protective equipment to protect us, right? And again, I'm thinking in my mind right now about people who work in meat processing plants, right? So why is it? What is it about context? Well, typically it's people who have fewer economic opportunities and so have less choice about where they work. The nature of the work, because they have less choice, they have less leverage against employers often, and they may be forced to work in conditions that are less safe. And the nature of the actual work requires them to be on top of each other and working very quickly and moving around and actually exerting themselves, right? So all of these things are related. So we think about proximal causes, we think about individual characteristics, but context creates a landscape that relates, that kind of, or shapes these proximal causes. And oftentimes the context is different for people with different characteristics, with different ages, different income levels, different sex, different gender, different race. Okay, I'm going to actually skip this one for a minute here. Okay, so if we think for a second, I want to go back to this idea of how do we measure disability. One common way to measure this is the disability adjusted life year. This is maybe less relevant if we think about coronavirus, but it's important for other non-fatal conditions. The disability adjusted life year is this effort to find a way, a common metric that captures mortality and time lived with disability. And so at DALY, or disability adjusted life years, your years lived with years of life lost plus your years lived with disability. Okay, so let's think through these a little bit more, right? So years of life lost. This is relatively straightforward if we think about this. And what I want you to kind of focus on is if somebody dies early, right? So if somebody dies from a particular condition, how long would they have lived, right? And we can think about this for COVID-19. We could think about somebody who's a woman who's 56 and contracts this because she's working as an essential worker in a grocery store, and we could ask ourselves, well, how long would she have lived otherwise? Well, that average life expectancy for a woman in the U.S. is almost 80, and so we can think that somebody dies at 61, they've lost almost that 20 years of life. There's lots of questions when people think about this, those years of life lost. Does it matter what age you do it at? Does it matter if you're a 5-year-old if there's a 5-year-old who dies, does their 6th year and their potential 70th year, do we value those in the same way? And these are ethical questions that we could go into, but it's just, the idea is this notion of measuring not just who dies, but also what was the extent of premature mortality? How many years of life did they lose? Not saying this is a right measure, but it's a measure that gets used. The second part of that disability adjusted life years, which is a little bit harder to kind of think about, is the years lived with disability. Okay, and so you're probably saying it's like, well, it depends on how bad the disability is. And this is a complex question because it's and so I can think about living with a kind of a modest or a small disability for a long period of time, or having a chronic illness that brings great pain, great loss of mobility, great loss of functioning, and these could be quite different, right? So we want to think about duration and magnitude. Okay, and so we can think about this. Imagine if we had a population where the average life expectancy was 70 years across the bottom here. Imagine if you lived in full health. This curve here, or this kind of area under this curve, you can think of this as your full kind of endowment of health. When you're born, this is what you'd have. Full health for 70 years. That's not a real life expectancy, but we can think about that as the amount, right? And so we can think about somebody who dies prematurely. And this kind of new white area is the years of life lost due to premature mortality. So we can think about that. But then we can also imagine somebody who at age 36 develops a chronic illness, and it's debilitating. It kind of goes down over time, so their quality of life goes down, and then they die prematurely at age 53, let's say. And so for this person, we can think of this as, in some sense, conceptually, as the years lived with disability, and this is our years of life lost. And again, we can think of lots of challenges to this idea, but the point is to count both premature mortality and disability and kind of reduced functioning. And we could also imagine somebody who goes through a period, contracts a condition, then has a full recovery and leads a full life after that. So that's why this notion of disability adjusted life years was developed as a means for measuring burden of disease. There are, of course, the question is, what do we consider the weights? What's more severe than other things? The first developments of this global burden of disease used experts to come up with ideas about what's more important than something else. And so they came up with these different disability classes. Increasingly over time, though, these assessments have become more, what do people who live with these conditions perceive these conditions to be? One of the key things is if you're a sighted person, you may decide that somebody who's blind is very disabled. But somebody who's blind might say, actually, I live a full life without any problems. So maybe we don't think of that in the same way. And so there's questions about whose perception is important. The other thing to think about is that many conditions the disability depends on your context, right? So if you're somebody who's lost the use of your legs, but you're in a context where everything is wheelchair accessible and you have access to a wheelchair, that's really different than if you're in a context where nothing is wheelchair accessible and you're not likely to be able to afford a wheelchair. So you can just think of these as different measures. You can actually look up different measures for different, or disability weights for different conditions based on this. But I don't want to go too much into that. Okay, I want to talk briefly about this question about risk factors and social determinants of health. And we're already kind of talking about this in the COVID class. And I want us to just think how do we go from a health perspective of thinking of this to a much more social perspective? So how do we kind of go from what epidemiologists who study patterns of disease do to how we might look at this from a sustainable development point of view? And the first thing is to think about risk factors. And again, from a biological point of view, we can think about kind of two different kinds. What we think about the question ask yourself, are individuals with a particular characteristic or a particular exposure more likely to experience a particular outcome, right? So this could be characteristic, could be their age or their gender. Their exposure could be, do they have a safe source of drinking water? What's the level of their indoor air pollution or their indoor air quality? What's their diet? Do they have, what's their blood pressure? We think of all sorts of different kind of risk factors that are characteristics or exposures, right? So these could be physical environmental exposures, or they could be exposures to a condition. And we think about how those affect different outcomes, right? What we want to be thinking about is that these risk factors are often key in understanding how development and health are related, because development or kind of sustainable development characteristics or economic conditions often affect our exposures. They're less likely to affect our particular individual characteristics, but they do affect our social and our environmental context, which affects our exposures. Okay, one way I like to think about this is if I think about a health outcome, we could think about what are the different risk factors for it. And we'll talk briefly about this, but even figuring out what are the biological, we can think of biological risk factors or behavioral risk factors. So what's the effect of exercise on cardiovascular disease, or diet or having a high-fat diet on cardiovascular disease? Or we could think of the risk factor of developing respiratory infections based on the level of particulate matter in your air, right? So these are things that can be measured fairly objectively. So these are exposures, different kind of individual or environmental exposures. And we can think of different ways to measure these effects, but that's what epidemiologists kind of do. They figure out how does a risk factor contribute to an outcome. And there's usually a good literature about what those relationships might be. We can also, our epidemiologists often think about confounders. And confounders mean that, so from an epidemiological perspective, they suggest that age, these are factors, things like age, socioeconomic status, your setting, for instance, or your rural or urban setting. Confounders are things that both affect risk factors and might affect an outcome, right? So we might think of people who are of a lower socioeconomic status might have a certain set of risk factors based on their diet, but they also may have other outcomes because of they may have a particular outcome because of other reasons, because of other exposures as well. And so it's hard to measure these relationships without accounting for these confounders. Sometimes these confounders also tell us something about social determinants of health. What is this relationship? So as we think about this especially for our coronavirus class, we want to think about how things like socioeconomic status, race, urban versus rural, age, how these affect risk factors and why. Why is it that certain one group might be more likely to have a certain risk factor, and it often has to do with power and options and other kind of broader structural inequalities, and how does that maybe affect their likelihood to have an outcome. This idea of thinking about confounders as kind of underlying factors which affect risk factors, which can affect an outcome. Okay, I'm going to skip this for now. I should have left this out. Anyway, I just want to leave us with this. We can think about these, we can think of like a simple biological model where we think about risk factors and outcome, but we want to be thinking about is how social context also influences both the outcome, but also these different risk factors. I hope that's helpful. I'll do a couple more of these short lectures to just as a point of reference for our conversations. See you soon.